I'm Eric Gordon. And
I'm Nafysa Parpia. Welcome. I'm so happy you are all here from all over the country, all over the world. We're just so happy to share with you.
Yeah, because, COVID, long COVID, post-vaccine injuries, these, have been difficult because, though they can look a lot like things that we thought we had some answers for, MECFS, fibromyalgia. Though, to be honest, there's no black and white answers because if you listen to us, you'll understand that these illnesses happen for multiple different reasons. And it's just that the end results, the symptoms that people are suffering can look the same. But how you got there and what treatment you need often depends on your own individual biochemistry. And that's what's and genetics. And that's what's so frustrating, because you can be online or go to your doctor and get what look like great answers and great suggestions, and it worked for these people, and then it doesn't work for you. And so what we're going to try to do today is just talk about some of the generalities and some of the specifics, and hopefully just give you a wider viewpoint to look at this from, and hopefully help you on your healing journeys, or if for that of your friends or relatives that are unfortunately in the world of long COVID. So, Dr. Parpia, I thought that the first question that people sent in was actually an excellent one, is what can you do if you have MCAS, which is Mast Cell Activation Syndrome, and long COVID, whether you had it pre-existing or whether it appeared as a symptom of long COVID?
Yeah, so I'd like to give a quick synopsis of what MCAS is, Mast Cell Activation Syndrome. This could be an entire webinar, and it should be of its own. So I'm going to talk about it briefly right here. So for those of you who don't know what Mast Cell Activation Syndrome is, it's when your mast cells, which are your oldest immune cell of your body, become hypersensitive. So normally mast cells should, normally they trigger histamine and a repertoire of 1,000 other chemicals when we have a sensitivity or an allergy to something. And that should be a transient effect. So just say someone's allergic to a cat, they visit a friend's house, they get itchy eyes, runny nose, they go back home, and those symptoms go away. That was an appropriate transient inflammatory reaction of the mast cells. Now, for most of our patients, they're having their mast cells triggered constantly. They're stuck in this loop of immune dysregulation. Mast cells exist in many different parts of our body. They line our nerves, they are in our gastrointestinal tract, they're in the brain, they're in the bones, not just the skin, not just the eyes. So our patients will have symptoms in all of these different areas that I mentioned. So that's mast cell activation in a nutshell. So the question was about how do we deal with mast cell activation syndrome? Well, the first thing I want you to know is that mast cell activation syndrome is a secondary illness. It's caused by triggers. It's not just, oh, I have that as a primary cause. Absolutely not. There's drivers to that. So those drivers are usually a combination of infections, toxins, stress, could be structural integrity issues, all of these things causing inflammation, which then tip off your genes to express, and then mast cells become highly activated. They become aggravated because the body keeps thinking it has something to defend. So how do we go about treating this? The first thing I do is, well, I think of it as putting Band-Aids actually on the immune system at first, because I know that I've got to remove the triggers at some point. I'm going to, but if I try to remove the triggers, that can further exacerbate the mast cells. So the question is how do we handle mast cells when we have something like long COVID or other infections going on? Usually it's the infections or other insults of the system that are one cause of long COVID for sure. So like I said, I want to modulate the immune system. So I will be using peptides. That was part of the question. So peptides like KPV, Lexinox help to modulate mast cells for sure. T4 frag can do that. I'm also liking to add in certain medications like ketotifen and cromolyn. The ketotifen will stabilize the mast cells. There's a lot more that needs to be done individually for each person, also to understand why this is being triggered constantly, but that's a good first step.
Yeah, and just to emphasize, because the person who asked the question, that's why I figured you'd do a good one in answering it, was really looking for what we can do other than the antihistamines and mast cell stabilizers, because that is what generally is done for mast cell activation. And that's where the peptides are a newer addition to the repertoire that Dr. Parpia has been using for quite a while with really good results. I mean, I think that's what people have to see, because the antihistamines, though amazing for some people, often have a lot of side effects,
Right.
and that are unpleasant in themselves.
Right. So, I used to use more antihistamines, but now really I will use ketotifen, which is a medication from the compounding pharmacy, and cromolyn from the compounding pharmacy. It's pure, there's no additives, no fillers, no colors. My patients are not rejecting those things. And I had to use other antihistamines instead, but not anymore. I can replace them with peptides. Now, there are some patients, they're few and far between, but there are some who can't even tolerate the peptides. You might be one of them. They need to be done very, very carefully and at low doses. I wouldn't recommend just grabbing the peptides and starting them, just like with any medication or any supplement. It's got to be under the watch of somebody who's experienced in using them.
Yeah, and often we also, and this is another place where low dose naltrexone can be helpful, because it's basically mast cell activation. In fact, when long COVID was first being discussed, I mean, it was really early on, even in 2020, by the summer, when we were realizing that people were having problems, long after the acute symptoms were gone, there was a lot of doctors, I shouldn't say a lot, there were a handful of doctors who were realizing that there was an aspect of mast cell activation going on. In fact, some of them thought that was the whole story. So there's been a lot of experience amongst doctors who are willing to try things using mast cell stabilizing medications. And what's always so interesting in this world is really when it comes down to it, we're just trying to quiet down the overactive immune response for almost everything. And that's why many different things will work, like LDN, which is another way to quiet down the immune system and help normalize its response. So people often don't think of it directly as a mast cell stabilizer, because it's not. It really is working more on other parts of the innate immune system, called toll receptors and other parts. But because the system is a system and everything talks to everything, anything you can do to quiet things down will be helpful. So that's not the whole mast cell story, but that's a little piece of it. But there's so many other aspects that people had questions about. And I'm trying to think of these. Yeah, if Darcy wants to, because I was. It's sort of nice to hit the individual questions before I go to the global issues that the questions are reflections of. So, Doctor, what was the second question?
The second question was, one of my questions is recommendations for treatment, what to do if you already had mast cell or MECFS or similar comorbidity and then got long haul COVID, wherein those conditions are exacerbated.
All right.
You go first.
Okay. I would say the reason those issues are exacerbated are manyfold, but one of the ones I see the most in my practice is that the reasons that somebody had chronic fatigue syndrome or fibromyalgia or post-tick-borne treatment, post-treatment tick-borne illness or chronic Lyme, one of the reasons people have that has to do with other underlying infections. So often the herpes viruses, Epstein-Barr virus, cytomegalovirus, HHV6, or things like Mycoplasma pneumoniae, Chlamydia pneumoniae. Infections like that can be dormant, but then be awoken up, if you will, through spike protein and through the inflammatory cytokines that come about from COVID. So if you once upon a time had chronic fatigue syndrome or fibromyalgia or chronic Lyme, I want to understand what it is that was awoken infection-wise from the spike protein or from the inflammation from it. So it's usually infections. Yeah.
Yeah, and you know, just on that, the people have talked a lot about the T cell exhaustion, which is you know, like sort of the what do you call the CD8 cells, the cytotoxic T cells, or natural killer cells, that they're not functioning as well. We know that happens with acute COVID, and in some people it persists, and that is also believed to be one of the issues for many people with MECFS that has allowed these persistent viruses, you know, because when in some people they really are recurrent infections. In many people it's recurrent immune activation to the bugs, because these bugs have co-evolved with us, many of them. Okay, so having them in your body is not necessarily the problem. The problem is the inappropriate immune response. Your immune system should be able to keep those things in a fairly dormant state. And if it doesn't, or even if the bug stays dormant, but your immune system feels the need to keep hitting it, you're going to stay feeling sick, because it's the immune system's activation that gives those wonderful viral feelings, most notably the myalgias and the fatigue.
Right, and absolutely. I love to test for that by looking at both antibody and T cell tests. So if we run antibody tests and we see that for most of the herpes viruses or the other infections I spoke about earlier, if all of them are high, I'm really starting to think that's the immune system that's hyperactive. It's not necessarily that these are dormant infections. If we do a T cell test next to that and we're seeing a T cell called interferon gamma that's lit up, that's high, I am thinking that we are fighting that infection. So thank you, Eric, for that. That's an important distinction to make.
Yeah, when the bug is, because there are a subset of people with long COVID and especially with MECFS who do respond to antiviral therapies, whether they be herbal, intravenous, or medications. But the difficulty is figuring out who is who, because the symptoms and most of our blood tests don't tell us that well. And what the test, looking at the T cell activation test that Dr. Parpia was talking about, we believe helps give us an indication of what is active and what may respond to therapy.
Right. I was going to say, I think that it's often we've got both going on at the same time. There are dormant infections that have now become active again, and I think there is a hyperactive immune system at the same time. And on the other hand, the immune system is too weak to be able to adequately fight the infection that is now awoken. So
yeah, it's a little bit like the fire alarm is ringing really loud, but the fire department is undermanned. You know, so your immune system makes a lot of noise, which is unpleasant for you, but it's not strong enough to really sequester the bug or get rid of it completely, as is sometimes possible. And one of the things that we've noticed when we did our interviews with other doctors throughout the country, I mean, that actually really kind of inspired me, was how few, especially we spoke to a bunch of them who had practices similar to ours, where they had a lot of people with, chronic Lyme or chronic fatigue, and they didn't have hardly any. In fact, most of them said they had none or no patients of their own who developed long COVID, that all the long COVID patients they were seeing were new to their practice. And that was exciting, because we were very concerned in the beginning of COVID, as were our patients. I think that, my God, that COVID was going to be the worst, was a sure bet to really worsen their previous chronic fatigue symptoms.
yeah, most of our patients did just great when they had COVID. They didn't develop long haul. I think that's because we were pressing on those infections already in treatment. We're already modulating their immune system. So when COVID came along, dormant infections didn't really have a chance to rise up they were being treated, the immune system didn't really have a chance to go off the rails because it was already being modulated. So it was really
It was validating.
Yeah, it was wonderful.
It really was
Yeah.
validating that you know, making sure that people were on, you know, the basic supplements, making all our patients, you know, we've always made sure that their vitamin Ds were adequate, that their glutathione was adequate, that selenium and that, you know, vitamin C. Those are just the basics. The basics were all covered, and
but beyond the basics, though.
Well, hopefully
like
a little
with
bit.
the peptides and killing off infections and all of that.
The bottom line is that we didn't see long COVID. Now, I mean, again, I'm sure there are patients out there who were taking those things who unfortunately have developed long COVID, but by and large, that was not the experience, which is exciting. Now, getting back to what we have today, we had a lot of questions that related to what I call, what people call vasculitis, you know, and as well as heart disease, you know, or heart symptoms post-COVID. And I think it's probably better to talk about them in general, because I think it'll be helpful for most people. So, you know, first of all, just starting about blood flow. I'll let, you know, Dr. Parpia talk about, are you interested in talking a little bit about blood vessels and spike protein?
Sure. So spike protein can get trapped in blood vessels and cause inflammation there, can cause clots. I'm not talking about big clots that would give somebody a pulmonary embolism. I'm talking about micro clots. And so we see issues in people's vascular system. We think due to that, we can help resolve it with things like NATO kinase or lumbrokinase. Some doctors are giving heparin. Yeah, Eric, would you say?
Well, yeah. In the big issue that I find in working with patients in this area is deciding, you know, when we're dealing with the issue of quote unquote microclots, or and when we're dealing with the question of increase of increased inflammation in the blood vessels. And so we have, let's see, like three areas, I guess I would say. There is the area of just the lining of the blood vessels, the endothelial cells, having retained spike protein, okay? And that will cause a lot of local inflammation and perhaps vasoconstriction or tightening of the blood vessels in small areas of the body, and then you get a whole downward spiral of local inflammation and poor blood flow, and that can come and go. So you can get those symptoms that come and go, get better or worse. The issue of people asked about COVID toes, right. And you know, and that probably is an issue of vasospasm. It might also be microclots. Okay, and so the
microclots causing vasospasm.
Yeah,
right?
Exactly. This is the circle. And if you're familiar with Dr. Pretorius's work from South Africa, which raised the possibility that a lot of long COVID is due to microclots. And it may be, unfortunately, the test that she used is one that's available in some hospitals, but it's only available for use in, you know, with patients in the ICU, because it's something that has to be done right on the spot. And it kind of tells you how the blood, you know, the tensile strength in a way, of the local blood clot.
I see a lot of questions popping up right now asking how to test
which is
for this. So
welcome to what we would love to know. There are right now, I think, 3 places in America, and I don't remember where they are, that I think are experimenting, but at this point they're not offering it to all comers to try to be able to see these microclots, you know, both on microscopy and through this test, which basically actually is a microscopy test. That's what makes it difficult. It's not like something that ever is going to be able done simply at LabCorp or Quest.
Maybe one day.
Yeah, maybe.
Not for a while.
Yeah, well, we have to change the technology to get there. So the big question is, how do you know if you have microclots? And at this point,
I'd say by symptoms, that's all we can know.
Yeah,
At this point.
because the test that I think we might be able to get some hints, but unfortunately, the classical test for excess clotting in the body is something called D-dimers, okay, which go up really high in acute COVID. But because these microclots are not normal fibrin, are not normal fibrin, and that's just a little, fibrin is the chemical that your body makes that forms a lot of clot, okay? That's kind of like the thing that holds the clot together. And normally your body breaks that down quite nicely, but when they form a different kind of sheet, a different kind of three-dimensional structure, the enzymes don't work that break that down. And the D-dimer is a measurement of the byproducts of that breaking down. So if you're not breaking down your microclots, the D-dimer is normal. Now, there are some other tests that we look at, but they're not definitive, okay? There's thrombin, antithrombin, and a few others that suggest that there's more, because these microclots will cause a little bit of more regular clotting. So you can get some hints from some of these subtle tests, but the bottom line is we don't have a great answer. And then you're confronted with the question of what to do.
Right. Someone just asked about NATO kinase, which absolutely.
Yeah. So using nattokinase, seropeptidase, lumbrokinase, fish oils, krill oil. These are all things. Well, I should say the nattokinase, lumbrokinase, and seropeptidase are things that help your body break down clots, okay? And some of the other enzymes may help. I mean, it seemed to help a bit. What the doctors who are treating these intensely, and we do this occasionally, they're using what they call triple therapy, which is using an antiplatelet medicine, aspirin, and a
heparin,
or most of them use heparin just transient, and then they'll move on to take these newer medicines which block the clotting, will inhibit the clotting pathway. Now, the antiplatelet medicines I think are worth trying. You can often get your local doctors to give that a shot because they do help a lot of people. Okay, especially with the COVID toes. Okay, and just I've had a lot of folks who've had good responses to using these platelet medicines called Plavix and Platel and Brilinta. Those are the brand names. Pardon me, I always have trouble pronouncing the generic names. And these are fairly safe. If you read about them, they'll sound terrible, but they are actually fairly safe. One of the doctor in South Africa who's been treating people with the triple therapy, which includes things that really do inhibit blood clotting. They are true blood. These are used for people who have deep vein thrombosis or atrial fibrillation, where there's high risks of blood clots going to your lungs or your brain. And these are drugs that definitely can cause bleeding if you hurt yourself. And he out of 300 and something people, he's had 2 people who had what medically we'd say severe bleeds, and one was a nosebleed and one was a GI bleed, which is significant, but still he's had about 80% people do well. I mean, and have over a few months have really good recoveries. So I think this is worth pursuing, but again, there are risks. So we don't go so fast there.
We should go into another subject.
Yeah. Oh, I have to throw out one more quickie on this, and for those of you who are Dr. Patterson aficionados, and his testing, and that was one of the questions that people asked about, what to do when you have this elevated VEGF, which is vascular endothelial growth factor, and soluble CD40 ligand, which is the SCD40L. You'll see it on your test if you've gotten that one.
He's talking about the long hauler panel.
From Dr. Patterson, the InCell.
Yeah.
Yeah, InCell Diagnostics or Radiance.
Radiance.
Yeah, they're all the same. Anyway, so these are very interesting tests, and their protocol usually is very heavy to using two medicines called statins, basically the medicines that people use to lower cholesterol, because they feel that will prevent the white blood cell called the monocyte from sticking to your blood vessel and creating local inflammation, okay? And the second medicine called Maraviroc, that I realize if we keep going with this, I'll take all the time talking about this. So I don't, I don't think that's probably fair to everybody, but I can just let you know that, again, these treatments do work for a subset. I think Dr. Patterson is a little too convinced of his amount of success, but we have seen these work for people, and I also seen them work and then not work. And so, again, it's the right population. It would be wonderful if we actually could test people with the, compare these various treatments against one another.
Everybody's different.
Yeah.
I think that's what's really important. Everybody's different. So these treatments will work for a subset of the population who have certain things in common, but there's a lot of people whom this will not
Right,
work
that's
for.
but what I would
Right,
like to know, because these are treatments that have downsides. And, and that's why this is, why your local doc is often reluctant, especially if the only thing he knows about it is what the article you brought him in. But I can say these all work for the right people, but we're still figuring out who the right people are. And, but we start slow. And you have to try these things, but that's as far as the vasculitis part. Let's shut up on vasculitis and blood flow, but we'll maybe come back to cardiac near the end.
Darcy, is there another question?
We've got so many questions. We'll be here all day. Let's just go. We're going to take a left-hand turn. I'm going to ask the question here from an anonymous attendee. It seems that chronic illness is often associated with Th2 dominance. What conditions lead to Th1 dominance? And is there a test or clinical diagnostic criteria to determine if someone is Th1 or Th2 dominant?
Okay, I'm gonna let Eric, this is a subject we talk about all the time. I'm gonna let Eric start talking about what we think about just Th1, Th2.
Yeah, I just think it's a nice concept, but it's not, don't hang your hat on it, okay? Because it depends where you're measuring things, okay? We've got into so Th2 is associated with allergies and parasite infections, okay, and parasitic infections. And so sometimes, if you have persistent viruses or bugs, sometimes they can try to fool your immune system and tell them to increase that Th2 response, okay? But as far as this, you can order antibody panels. I mean, not antibody, cytokine panels.
The lymphocyte map by Cyrex.
For instance, or cytokine panels, okay? Where this story breaks down is when you try to get to the specifics, okay? It's a very useful tool to think about how the body works, but the only way, and you can measure, obviously, the Th2 lymphocytes, because the Th1 are the CD8 cells more, and the Th2 tend to be the CD4 cells. But it doesn't really give you answers. You have to look at the clinical patterns, because if you just look at the cytokines, people often would say that like IL-4 and IL-13 and IL-10, are more the things you see with Th2 things, like you'll often see, but it doesn't work out that way because it depends where you measure them and what else is happening. So you can get some gross ideas, but
basically, there's hundreds of different biochemical reactions happening, thousands happening in each person that's different, and it's all coordinated in each person differently than in the person beside you, and then genetic expression starts to happen. More inflammatory chemicals get thrown out, and so now we're looking at so much more than just Th1 and Th2. It could be a small beginning to look at, but there's a lot more that we need to take into consideration.
Yeah, I think that's exactly it. It's like you're looking at a picture and you're looking at the left-hand corner, and you think you can interpret the rest of the picture by what you see down in the left-hand corner. And it just doesn't work. Now, again, you can use it if somebody has a lot of allergies. Yes, you can say, oh, that's a little Th2 dominant, and you might want to adjust your supplements accordingly a little bit. And in some people, that really works, okay? But in most people who have been ill for a long time, that breaks down. And again, useful tool, but I wouldn't get attached to it. It's just, I haven't seen it make a difference in people with chronic illness. In people who have allergies, yeah, it does. Because then you want to,
simple model.
yeah, that's the model that works. Lowering Th2 intermediate, like cytokines, does help.
Next question.
Awesome. Okay, I was pausing for a second. My concerns are about long-term mold in sinuses and brain after years of co-infections such as Lyme, lead, West Nile virus, and COVID following severe mold infection.
You sound like our patient, all of our patients. So yes, this is what we see all the time. And I think that colonization in the sinuses is an underappreciated topic. It's something that I look at in almost all of my patients because inevitably I'm finding colonization in there that I think shouldn't be in there. I'm finding funguses or bacteria like Klebsiella, or I've even found some E. coli in there, things that are not expected to be there. Now there's recent research that shows, I think the research just a year and a half ago, that shows that inflammation of the sinuses does change cognitive function, executive function, mood, sleep. So there's this direct effect of inflammation on the sinuses this direct effect of brain inflammation from inflammation in the sinuses. So inflammatory cytokines can cross the blood-brain barrier. Mycotoxins can cross the blood-brain barrier. So the question was about what can happen due to inflammation in the sinuses. It is that it can cause effects in the brain. So that's why I'm very eager to treat the sinuses of my patients when it's warranted. And then I also want to bring down inflammation in the brain after I treat the sinuses. So I'll often do that with peptides. Now, I'm not using those nootropic peptides while the infection is still, or the colonization, I'll say, is still there, because they're just not going to work. It's like trying to rebuild a house when it's still on fire. It's not going to work. So we need to put the fire out first, and then we rebuild. So put the fire out, meaning treat the infections first, and then bring inflammation down in the brain and in the sinuses.
All right. Do you want to add anything else, Eric? Or
No, sounds. I mean, that was a great explanation, and the issue of sinus colonization and has been one that has been ignored, but we see amazing results when we treat it.
Yeah, brain fog, depression, hormonal issues. Look, our patients have so much more than issues in the sinuses, right? So that's going to help chip away at everything else that's going on with our patients. We have to deal with the other infections, deal with the other toxins, deal with immune system regulation. There's so much that we need to do. It's one piece, but it's a very important piece.
One other quick question that came up was your feeling on oral peptides versus injectable peptides.
Yeah, I find them both very, very helpful to people. Sometimes with the injectables, people can hurt. It can cause a little bit of a burning reaction. I'm finding that both of them are actually very, very effective. So it really depends on the person. Some people don't like swallowing pills. They'd rather inject. I'm using a combination of both depending on availability, because I can't get them available in all forms. So whatever I can get my hands on. And if the patient is willing to inject themselves, if there isn't an oral, then that's great. Some people just don't want to inject themselves. So then they won't use that peptide because I can't get them. Thinking of things like LL37, for example, which perforates holes in the cell walls of infections. I can't get that in oral form, but I can in injectable. So really it's a matter of choice and availability. As far as effectiveness, they're all effective if they're sourced from the right place.
Great. So we've got, I'm going to take two MECFS questions and actually put them together. One attendee says that he or she has had MECFS for 30 years and still has bouts of intense body pain that causes migraines, and they would like suggestions. There's also someone else asking about, are there any medications to help MECFS?
Oh, there's I'm just laughing because there's a ton of medicines that help symptoms of MECFS. Okay. When it comes to MECFS itself, I don't think it's a thing. Okay. It's a collection of symptoms.
And a collection of causes.
Yeah. And it's, how do you say, like, in medicine, when you have something that gives you like a definitive broken piece, that's a disease we can all agree on. But when many illnesses are collections of symptoms, okay? I mean, even things like, Parkinson's is a good example. I mean, Parkinson's is not one disease. There's lots of different things. And half the people with Parkinson's have atypical Parkinson's, according to the neurologist, where they don't quite fit every criteria, but they definitely have, enough of it. They have a movement disorder and some other things going along with it. The point is, like when you have a pneumonia, you have a chest x-ray we all agree on, and it's kind of clear. Okay. So and that's usually caused by a handful of bacteria, usually, or viruses that we can define. So there's a cause and an effect, and they're pretty close together usually in time. Okay. But when it comes to syndromes, things like chronic fatigue, and Parkinson's and a lot of the other illnesses, there are endpoints, symptoms at the end that all are similar, but you got there for many different reasons. Okay. So I got lost in my circle here. Where did we start? Really did. I got lost in where I was going. What was the question?
Oh my God.
Yeah, I just love the story. I love the story.
I really like when you get lost in the moment.
Oh, chronic fatigue syndrome and a
yes,
medicine
and the medication.
And a medicine, yes. But this is the great dilemma. There's literally 30, 50 medicines that doctors use, for people with chronic fatigue for different symptoms. And they all work sometimes in some people really well for some of the symptoms. There are cerebral vasodilators that in some people helps their cognitive function. Just like we see for cognitive function, there's an ADD medicine, guanfacine, which affects the sympathetic nervous system in your brain. And for some people with MECFS and people with long COVID, that, plus some antioxidants really help brain fog. Okay, but it doesn't work for everyone. It just works for some people, depending on how you got there. And, you know, there are vasodilators that sometimes work for brain fog for some people. So there are lots of medicines that help the symptoms of you know, POTS and orthostatic hypotension. There are lots of things that will help your reflux or your sleep disorders, you know, and your muscle pains. We usually have to go to deeper things than just medicines, because I mean, you know, that unfortunately muscle pains usually have to do with more complex things like the blood flow issues that we were talking about. And with MECFS, again, there is a subset that do respond to mild doses of blood thinners or platelet modulators.
So I think what you're also saying is that there's ways to treat it symptom by symptom according to your body, but at the same time we have to uncover why this is going on. So all these great medications that you listed for symptoms are fantastic band-aids to allow you to feel well while we're searching for and treating the root causes and modulating the immune system, because sometimes we can take the root cause away, remove it, but the immune system is still in disarray. So
yeah, and still stuck in inflammation. I think that's what's so frustrating, is because, you know, again, like I said, with pneumonia, you know, there are herbs or there's antibiotics, and if it's acute pneumonia and it's bacterial, the antibiotics are kind of magical, and that's what we grew up on. That's what we're looking for. And when we're dealing with these messy, complex illnesses that are different in different people, I mean, that's what it keeps coming down to, and is so frustrating for the patient and the clinician, is looking, and just to address, I think what Dr. Parpia pointed out that is so important, is that so many of these treatments, when you look at these medications, they're going to deal with a symptom. But if we deal with enough symptoms, okay, we can sometimes find the root cause or treat the root cause, but actually sometimes we don't even have to be so good. We just have to treat enough symptoms that the body starts to feel safe, okay? You don't stop feeling sick all the time, and then healing actually can happen. I mean, you know, I know sick people can be really sick and tired of people telling them, oh, just relax and meditate and you will be healed, you know, and that's very frustrating when you've been sick for 10 or even for a year and you get that. And, you know, again, yeah, meditating and relaxing helps everything, but it's not enough. But at the same token, one of the secret of returning to health, once you removed the big triggers, is the body feeling safe again. And so the less pain you're in, the less, you know, if every time you stand up you get dizzy, if that goes away, your body feels a whole lot better. Okay, not necessarily, it doesn't mean you're going to go out and run, but it means that you're not getting this big danger signal every time you stand up. And that's happening, you know, autonomically. It's not about how you think about it. It's just about how your limbic system reacts to that very fearful thing of suddenly you're either dizzy or your heart's racing. I mean, that just yells danger. And that keeps your immune system upregulated, and it gets in the way of healing. So, to long story, that's why all these different medicines that aren't going to, or herbs or treatments, because there's a lot of treatment modalities that will also quiet some people's immune systems. I mean, just to mention them, you know, like all the PMFs and the magnets and the electrical stim devices, you know, in the right person, those can really help. But be careful, because there are people who have become so sensitized that even what should be a healing message from those devices can be too much and set you off. So if you are interested in those things and you are very sensitive, start very slowly. Okay, so I think we kind of covered a bunch of that.
That's great. How do you treat someone who has developed severe anxiety post-COVID?
Tell them to relax. No, that was a joke. I hope you know that.
So I wonder if that person is wired that way to begin with just a little bit, and did that get amplified after COVID? A lot of times I'm seeing that people's normal emotional state becomes way too big, right? A little bit uncontrollable. So I'm wondering that, or I'm wondering, is this not who you are at all? Is it a totally brand new thing? I'm probably going to approach these things a little bit differently. If it's something that's not familiar to you, I am thinking about other infections, because it's very rare that I'm going to find somebody who has a sudden onset of a non-luminous emotion that's not connected to infections. So I'm looking for that. If it's something that you're already familiar with, well, I'm probably still going to look for other infections. I'm going to look for inflammation. Those are the biochemical possible causes for this infections. But I'm also very aware that there was a global emotional trauma going on, and that plays a big role, I think, in people's increased anxiety. All of the stresses that came with this pandemic, whether it was financial or familial, maybe you lost family members, maybe it was very, very hard to isolate, all these things. Now there could be a new pattern of emotions that were developed for you. So I want to investigate that. There's so much to think about. I am seeing more colonization in the sinuses of bugs that I never saw prior to the pandemic. Absolutely, very rarely saw. Now suddenly I'm seeing them. So I am thinking that inflammation in the sinuses that's new could be also a contributor. So there's just a lot to think about here.
And what I would, emphasize is well, two things. One, people are looking for treatments, and what you were talking about is, treating the infections, because is usually important. And most important thing here, if you're over 30 and, you were always kind of just normal person, a little, you got anxious before an exam or before public speaking, but other than that, anxiety wasn't your thing, and suddenly it won't stop, okay? That's a bug usually, okay? Could it just be post-COVID? Yeah, I guess so, but less likely, okay? In our experience, it's more likely that there is, especially the tick-borne illnesses, they really can hijack your emotions. And it sounds weird and sounds kind of crazy, but I've just seen it over and over again.
Mold can as well. It's a combination of those two things and other infections. So it's very important that you
look for that again, especially that point where something is really new to you, and it can be anxiety, it can be depression, obsessive compulsive, more than just thoughts, but almost a disorder where it really getting in your way of your life. If that's new to you, you got to look harder for the bugs. If on the other hand, you were always kind of wired, and even as the kid, you worried all the time, then it just could be increased inflammation that's driving it.
Right.
And that's where using, again, the peptides are really helpful. Some of the herbal things are helpful. Just, the boring stuff works, okay?
Peptides and herbals are not
No.
boring.
I mean, like there's no magic wand. It's just, meditate. I mean, but the point is, you often need something to quiet your immune system before you can begin to get the benefits.
Someone likes your jacket. I chose it for him.
Yes. Yeah. Closed by Dr. Parpia. But I think that's the most important takeaway here. If the mood is brand new, you really got to look deeper. Okay. If it's just an exacerbation of your previous, just basically neurotic condition, because I don't know anybody who's not a little weird. I mean, we all are wired differently.
There's no normal.
I've never met a normal one yet. It's then, doing it because, biofeedback, hypnosis, all these things do work to help quiet mood, but if the inflammation is running rampant, you often have to work at the biochemical level, and that's where I keep emphasizing the peptides because they're not drugs. We like to avoid those because those are a devil's bargain. You might get a little relief for short term, but you can get into trouble because if it's not short term, it's just not good for your brain. Yeah, it's a shame because the medicines do work wonderfully in the moment, but they come with a price.
Yeah. We only have like 7 minutes left.
I know. There's a number of questions about if there's, I'm just going to say it like this, is there in a general order of treatment? If somebody has mold, Lyme, EBV, Hashimoto's, parasites, is there a certain order, or is it more than that?
I'm just saying, start. I'm a little bit, again, you can always say it depends on the person, but I know what Dr. Parpia is going to tell you is proved out to be true most of the time.
Not all the time.
Yeah, but most of the time.
So
I just want to emphasize, because people get too hung up on rules, okay? And when it comes to your body, you got to listen to what's happening inside, because you are different than the person next to you. And the guy who developed the rules, yeah, he didn't develop it on 1,000 patients, okay? He developed it on 5 or 10. And then he started, I mean, because I know the people who developed most of these so-called rules, and then they started using them. And once you start using rules, you tend to confirm your preconceptions. So, you know, these are good rules of thumb.
Right. So in general, I like to modulate the immune system first. Before the advent of peptides, I couldn't really do that, though I wanted to. So why do I want to modulate the immune system before I begin detox or before I begin killing infections? Because or mold. I'm going to lump mold in with both infections and detox, because mold illness does contribute to both those things, to high toxin load and to infections, to the mold itself. So I modulate the immune system first because I know that if I detox first, that's going to cause some inflammation. Inflammation just comes with the territory of detox. Same with infection killing. If I kill infections, especially chronic infections, because we're using substances, herbs, medications, whatever it is, for a long period of time, there's going to be release of biotoxins, inflammatory cytokines, byproducts of dying cells and dying bugs. Now, we have to take this back a little bit more. Most of our patients are stuck in a state of perpetual inflammation. So this inflammation that should have been just transient as a way to protect ourselves from the exposures, it's not transient for our patients anymore. They're stuck in this constant loop of inflammation. So I want to try to quieten that down, because I know that when I kill infections and when I detox the patients, I'm just going to amplify that loop that they're already stuck in. So with the advent of peptides, I can start to calm the immune system down. I can modulate it. Then,
can I just break you
Yeah.
for 1 minute?
Yeah.
Somebody popped up a very good question.
Yeah.
What is peptides?
What is peptides? I'm going to keep going.
Okay, well, we will answer that.
That's because it's
Okay.
another question. I don't want to lose the loop.
Okay, go. Okay.
Okay. So I'm modulating the immune system first, because now I can, with the peptides, which I'll tell you what they are in a couple minutes. Next, I am likely beginning detoxification. Now, before I can begin detox, though, I need to understand if the person can tolerate detox. What if the person has constipation? What if they have interstitial cystitis, or they have chronic UTIs? What if their hormones are imbalanced? If I'm trying to detox a person, I'm trying to flush toxins out of their cells, they can't handle that if they're constipated, or if they have interstitial cystitis, or they have estrogen dominance. So I need to balance the different systems of the body as best as I can. First, you can read my pre-tox ebook. It talks all about that. So I'm pre-toxing them, preparing them. It's different for each person. Then I'm going to come in and detox when they're ready. Then I'm going to layer in treatment of infections, the chronic infections. Now, why am I not jumping to treating chronic infections first? Because I want to work on the immune system some more. before I start to kill the infections, because usually they can't tolerate the infection treatment until I've detoxed them. And again, when we kill the infections, they're going to release more biotoxins. So why would I want to add more toxins to a patient who's already toxic, right? So I'm detoxing and then I layer in infection treatment. Now I'm synergistically treating all of these at the same time. So that's my general order of treatment. And it's going to be different for each person. I'm going to weave the treatments in and out and make it very, very personalized. Some people, I can start off with detox right away. Some people I can't. Some people, they've got an acute infection. I want to kill that right away while I'm balancing the rest of the system. So it's different for each person, but that's my general template.
Yeah. And, when it comes to viral versus the tick-borne illnesses, it can be hard, but generally when there's more, overwhelming fatigue and myalgias, that's kind of what the predominant thing. We look harder at the viruses, but if there are, arthralgic joint pains and lots of other kinds of weird pains, we look more at the bugs. Again, nothing's absolute. And one important thing, what Dr. Parpia alluded to, was we're talking about people who've been sick for a long time.
Yeah.
Okay, if you just got ill, you can often go quick. I mean, it's still, if you're really constipated or have Hashimoto's, and that's the point. You want to get the thyroid at least working decently. You don't have to be perfect. You don't have to have a really low. I don't want to go into details, but you just have to get it working, and probably pretty early. It's nice to have the organs happy, but the point is that if you're generally healthy and you just got ill, you can go much more straightforward. We're talking, our population is people who usually have been ill for years, if not decades, and then there's a lot of garbage to take out, okay? Because when you're sick, you don't take out the garbage, in your house or in your body. You tend to store a lot of it.
Spike protein we'll consider garbage that gets stored in the body. Just to loop this back into the conversation about long haul, that's also something that needs to be taken out. I'm starting to talk about autophagy right now, and that's a whole other topic. But intermittent fasting in the right person can help with taking out the garbage, or certain regenerative medicine techniques can help with that. Exosomes, for example. Let's tell them quickly what peptides are.
Oh, peptides. Well, peptides are small proteins. Okay, they're like anywhere from 3 to 40, 50, depending on your definition, amino acids long. Okay, so these guys are small. Enzymes can have hundreds to thousands. There's even one that almost has 1 million, amino acids. So they're really big. Peptides are small. They're often breakdown products of larger enzymes, okay, or larger proteins. Not all of these are enzymes. Things like MSH and KPV are actually derivatives of the same large molecule to begin with. And so it's like the body will first make a large molecule when you have the acute infection or acute insult. And then as you heal, these long molecules get broken down, and these breakdown products actually are information molecules as well, and except their information about getting the healing cycle going. Okay, because in the beginning, when the body's working well, you kind of like have to either kill something or stop bleeding or do something acute, and there's a lot of inflammation at that point. But then the immune system, whether it be hours or days later, should start becoming more of an anti-inflammatory system. Chronic illness is when you don't go through that whole pathway. You get stuck, at least, and often it's not your whole body, thank God. It's just some of the cells in some of your organs are stuck in inflammation. So the peptides are signals to those stuck places to begin to start, or to complete the healing. Okay, and this is something, you've heard me talk about the cell danger and Dr. Navio's work, and someday I'm actually learning how to tell this story without the biochemistry.
We have a cell danger response ebook.
Yeah, we have an ebook, but hopefully I'm going to have another webinar in the near future where we're going to be able to go through that. I think it's a very rich story to help you understand what's happening in your body, but without I used to tell it with far too much biochemistry, which kind of isn't useful to most people. So just really, the more I understand it, again, like anything, the more you understand something, you can make it into English. So I'm looking forward to that because it will help people understand why they're stuck and hopefully help them when they're busy out there reading, have a better idea of what might help them to complete this. We keep calling it a healing journey, and it really is, to get your body back to the point where it's not trying to fight anymore, but really it's now trying to find peace.
Yeah, you see my eyes looking over there. I'm just scrolling through the questions. There's so many great questions, and we just don't have time to answer them all. I think we need to do another webinar like this. Again, we've got so many great questions. Guys, thank you so much for attending and just joining us and being interested. So
yeah, a pleasure, really. And I love these things because your questions, we get to them, they make me think, because I don't have the answers to all of them, I'm sure. And every question always gives us a chance to learn a little bit more.
Yes.
So thank you.
Thank you.